when I'm going through and teaching hemodynamic monitoring, one of the things that I found really, really challenging when I first started studying for my FPC was this stuff. And I found that especially on the FPC, I had a whole bunch of questions on this. The nice part is you typically get a decent amount of information along with the numbers that you can kind of go through and figure out what's wrong with your patient. And so they might give you simple hints like you have all of these values, but your patient is wheezing. All right, well, that tells me that this is more of an anaphylactic shock versus anything else. Or maybe I have a patient where, you know, I can clearly tell that they're in a distributive shock. However, when I go through and kind of read a little bit more on them, their heart rate's at, you know, 60, which is not a natural response. That tells me that I'm in a distributive shock, but specifically, I'm looking at a neurogenic shock, if that makes sense. Oh, do you like to stop by, say hi in person? And thank you. Oh yeah, we would love to have you stop by Memphis. Check. So when I'm going through and looking at these, we have those printouts on the study guide that you guys are able to pull off the resource link, where it has all the different types of shocks and what you're going to see each value do. And to me, that was super, super overwhelming. And I couldn't really, you know, kind of place exactly what was going on with the patient. And so we kind of talked about this earlier today. You figure out where your problem is, and then you go from there. So you find out where your abnormal numbers are and then try to figure out why they are. So let's go through and do a couple of practice problems. Let's say, let me see, yeah, you can see this. If I have, let me see if I can get this all on the board so you can see it. I'll do CVP, PAWP, cardiac index, my SVR. Let me see. That is all, yeah. I'll see if, move this forward just a little bit, just so it's a little closer in view. Okay, so if I'm going through and I'm given a set of values, these are the 4 core values that I find to be the most helpful. So if I had a CVP of, we'll say my CVP is at 3, my wedge pressure is at 6, my cardiac index, say, is at 2.4, and my SVR is at 1200. Okay, so when I go through and look at these numbers, my CVP is at high or low. So CVP of 3 is more towards the low side of things because my CVP should be somewhere between 2 to 6. So my CVP I know is a little bit low. My wedge pressure is hanging out at 6. And remember, your CVP, I like to think about my CVP is what's being dumped into the right side of the heart. So I think what's coming back in from the system. If I don't have a whole lot of blood flow coming back into the system, I'm concerned. So I either have a pipe problem or somewhere along this, I have a pump problem. So we know that my CVP is low. So everything that's dumping into that right side is low. From there, I look at my wedge pressure. So my wedge pressure is telling me what's leaving that right ventricle, hitting into the pulmonary side. And that's also giving me an idea of what's getting fed into that left side of the heart, because that's what's, you know, we go from the pulmonary side into the left atrium, then into the left ventricle. So I know my feed in from the right side is low. My wedge pressure is hanging out at 6, which is low. So I know that that makes sense so far. If I have low coming in, makes sense that I have low pressure going into the pulmonary circuit. So then I look at my cardiac index, and my cardiac index is pretty much telling me how well this pump is functioning or how much fluid is moving through this part of the pump. So my cardiac index is at 2.4. So cardiac index, remember, different from cardiac output, but similar. And the way I like to think of cardiac index versus cardiac output. So if I have somebody, normal cardiac output is between 4 to 8 liters per minute, right? It's how much our stroke volume times your heart rate gives us about 4 to 8 liters per minute. If I had a linebacker, so we'll say a 350-pound linebacker, and his cardiac output was hanging out at 4, and I have little old lady, she's like 90 pounds dripping wet, and her cardiac output is 8. Are those both within normal limits? Sure. When I look at cardiac index, remember, cardiac index takes into account their body surface area. And this isn't a number you will ever have to calculate. There's charts and everything else for it. You will be given these values on the test. So I go through and I look at their cardiac index. When I match their cardiac output to the size of their body, maybe that linebacker, his cardiac index is now at 2, whereas little old lady, her cardiac index is at 6. Those are both very, very abnormal numbers. Whereas if I look at their cardiac output, they were within normal limits. So again, that's just kind of a way that I like to think of their cardiac index. So our cardiac index is at 2.4. It's a little bit low. It's not super low, but it's definitely a drop down. And then my SVR is at 1200. And remember, your SVR, your systemic vascular resistance, is how the body's responding. In any type of shock state, if we aren't getting good flow, the body's going to clamp down, right? So the body clamps down to try to feed blood back into the core organs. So we expect this to be somewhere high. If it's not high at all, we know that we have some sort of vascular tone problem, which is going to be associated with things like distributive shock. In sepsis, while it does fall under distributive shock, we do have some changes with that cardiac index with that. And especially in the early stages, as we start to get into like cold shock with our septic shock, then it all falls into that same distributive shock. So I know my CVP is low, my wedge pressure is low, my cardiac index is low, and my SVR is a little bit high. So that tells me that I don't have blood coming into the right ventricle. Therefore, I don't have blood going into the pulmonary artery. I don't have blood coming back into the left ventricle. So I don't really have anything to squeeze out into the body, but the body's saying, hey, I need more flow, right? So we're trying to squeeze everything down to get flow back into the system. So when I drop down all of my flow and the only thing that I have that's really squeezing, I don't really have any problems with the heart. I just have a low flow state through the heart because my feed in, my pressure throughout, and my exit are all low. That tells me that I'm hypovolemic. So this is somebody who's either bleeding out, maybe somebody who's just fluid deficient. There's some reason why we just don't have enough fluid in the tank. Does that make sense? Let me chime back over here onto the chat. Have I lost you? Hopefully that's a yep, it makes sense, not a yep, I've lost you. Awesome. So let's try a couple more of these. Let's say my CVP was at 9. Sorry, I erased those. So my CVP is at 9. My wedge pressure is hanging out at 15. My cardiac index is hanging out, we'll say it's at 3. And we're gonna give my SVR a solid, we'll give it 1150. So when I go through and plug these numbers in and I start looking at where my problems are. So my CVP hanging out at 9. 9 is high, right? So that means that as I have fluid coming in from the SVC and the IVC, the superior vena cava and the inferior vena cava, I'm running into a problem here. I've got a backup. So it's trying to come in, but the pressure's high. Remember, the right side of the heart, low pressure system. So concerning that my CVP as I'm dumping into the right side is a little bit high, I go through and I look at my wedge pressure. My wedge pressure is at 15, which means as I'm trying to go into the pulmonary arteries, as I'm getting towards the end of that, my pulmonary capillaries, they're under high pressure. The pulmonary capillaries don't like to be under high pressure. When we have increased pressure, now we're running the risk of pulmonary capillary leakage, which long-term is going to cause significant lung problems, right? So I have increased pressure going out into the pulmonary capillaries. I look at my cardiac index. My cardiac index, meaning the blood flow leaving out here of my left ventricle into my aorta, it's at 3. It's not super low, but it's still on the lower side of normal. So I'm still moving blood. My left ventricle is still so far functioning, but overall, not super happy with my cardiac index. And my SVR, I'm hanging out at 1150. Not super high, but as I start to approach that 1200, I'm already starting to see the body clamp down to try to deal with the fact that my cardiac index isn't really sufficient. So if I have my wedge pressure up, or I'm sorry, my CVP up, my wedge pressure up, my cardiac index up, and my SVR up, that puts me in one of two places. So if I look at my chart, my CVP is up, my wedge pressure is up, my cardiac index is up, my SVR is up. So at this point, I have to read a little bit more into my patient and find out what's going on with them, because it could either be a cardiogenic shock or it could be an obstructive shock. And so some examples of a obstructive shock, we start thinking about somebody who has tamponade. Do I have somebody who has so cardiac tamponade? I could have a tension pneumothorax, right? So things that I would start to see those associated signs and symptoms with this patient. I have absent breath sounds. I have somebody where, we could even you could probably even throw pneumonia into this as well, as we increase that pulmonary pressure just due to the infiltrates. But if I went through and said that this patient was complaining of 10 out of 10 chest pain, and I also had elevation in, we'll say, V3 and V4. Well, V3, V4, I already know I'm looking over here at the left side of the heart. That makes sense to me by saying, hey, I'm having problems with the function of this left ventricle. So my cardiac index is going to drop if that left ventricle isn't working. I already have that confirmation that, hey, I'm having a STEMI. So STEMIs are going to result in a cardiogenic shock or a left-sided failure. So that's another way to look at your cardiogenic shock, is your cardiogenic shock is a pump problem. So you don't have good flow from the left side of the heart. Okay, let's try another one. Good, you guys nailed it online too. If I have, let's say, a CVP of, let's say my CVP, sorry, I can't write from that side. My CVP is hanging out at 1.9. My wedge pressure is hanging out at, we'll give that a 6. We'll say my cardiac index is at a 2. And my SVR is hanging out at 600. So when I look at these, let me look at this. So the question online was, if a patient had an elevated D-dimer, those numbers would be obstructive shock instead of cardiogenic shock. Yep, absolutely. So when I started thinking, hey, do I have some sort of issue where a potential for a PE? And I reference back to my labs, absolutely. Good call on that. So on this one, we have my CVP. I note that my CVP is low. My wedge pressure, it's 6, is also low. My cardiac index is low. And my SVR is low. Where does that land me? It's definitely a pipe problem. And so what information would I want to know about this patient? Because there's a couple of things that can cause pipe problems, right? So do I think this is like end stage sepsis? I shouldn't say end stage, it's kind of morbid. But do I have like a cold sepsis where I've really lost that tachycardia from the heart? Or am I just hanging out in this distributive shock area? And so distributive shock, I would want to go through and look a little bit more into the question. And if I said that my blood pressure, we'll throw some more values in here. My blood pressure is, we'll say, 80/40. And my heart rate is hanging out at 62. Absolutely, gonna nail me right into that neurogenic shock, right? So not only do I have the information from here, and realistically, if you just start reading into the question, you may have already figured out that this was in fact a neurogenic shock just by the fact that, hey, all of these numbers look pretty low. My heart rate's low, my body's not responding appropriately. The only place that really puts me there without tachycardia is gonna be somebody who has a neurogenic shock. Okay, good. Through my eraser, check. Let's try. I have a CVP of 9. I have a wedge pressure of 6. I have a cardiac index of 2.2. And my SVR, we'll say, is at 1400. Okay, so my CVP, I note, is high. because it should be between 2 to 6. So my CVP is high, my wedge pressure is low, my cardiac index is also low, and my SVR is high. So when I stop and kind of really think about these numbers and exactly what's going on, I note that as I'm coming in from the SVC and the IVC, I have a lot of pressure. So I've got a lot of pressure here in the right ventricle. If I look at my wedge pressure, I don't have a lot of pressure going this way. So that concerns me that right here, I have a problem, but I have to continue investigating on this. So I go through, I look at my cardiac index. I don't have a whole lot leaving here. And then I look at my SVR and my body's saying, hey, I'm not getting the nutrients I need. I'm not getting the blood flow, the oxygen. Let me clamp everything down. So my blood flow out of the left ventricle is low. The blood flow in my pulmonary side of the house is low. My right ventricle is where I'm seeing the biggest problem, because as I'm getting blood flow coming into this right ventricle, I've got a blockage here. I have something that's not working. I have a pump problem over here on my right side. Makes sense, because now I've got to back up into the right atrium, into the inferior superior vena cava. So I've got to back up here because this pump isn't working. That plays into the whole concept of I don't have good forward flow here. If I don't have good forward flow here, I'm not going to get a whole lot of blood flow into that left ventricle. If my left ventricle isn't getting filled, my cardiac index is going to suck. If my cardiac index sucks, my body's going to say, hey, I'm hypoxic. Why don't we squeeze down, see if we can get some more blood flow? Why would this be a problem? Well, what things are going to cause that right ventricular failure? Things like cor pulmonale, right? So we start thinking about, hey, I've got somebody where I've got an isolated right-sided MI, right? So right-sided failure, perhaps, if I have right ventricular hypertrophy. So things that I'm thinking of, why is my right pump not working? And so if I have somebody where, say, they're having a right-sided MI, I've got elevation 2-3 AVF, I look at my V4R, it's also elevated. I can really isolate that, like my right ventricle is just getting tanked due to poor blood flow. Well, if this SVR continues to increase, because the body's saying, hey, let me fix your problem, because the rest of the body's responding with, help, help, I'm not getting good oxygenation, and we continue to clamp down and we continue to try to force more blood over here into this right ventricle, you can see where we can make that whole problem worse. And so while, yes, we do talk about we don't give nitrates in a right-sided MI, this might actually be somebody where if their pressure could take it, we could consider giving like a nitro drip or something like that to bring things down a little bit. We also want to make sure that we're giving them aspirin to go through and prevent further injury associated with this. That makes sense? Yeah, absolutely. So online we made the comment that it's a little bit easier to look at only 4 values instead of 5. And that's really the way I like to look at it. I look at 4 places. What's coming into the heart, what's leaving the right ventricle, and how is that affecting the lungs? And so I kind of look at, and while it's not necessarily appropriate to call your wedge pressure your lung pressure, but it realistically is. It's considered your left end diastolic pressure, what's getting dumped into the left ventricle. The way I like to think of it, and the way that makes the most sense to me, while slightly inaccurate, is what's coming into the right side of the heart, what's going out, and how are the lungs responding to that. So I could have something where I have really high pulmonary pressures, and so my wedge pressure is through the roof, but I don't have a backup here in the right side. Then I start thinking this is an isolated lung problem. And so I start thinking about things like pneumonia. I start thinking about specifically ARDS or ARDS, right? So I start thinking about those things if I'm isolated just to that pulmonary circuit. From there, I look at how is my left ventricle functioning, or what's my cardiac index, keeping in mind what's going into it. So if I have not a lot going in, not a lot it can come out, right? With the exception of early sepsis, where our heart rate increases, so our overall cardiac output, and therefore our cardiac index, is a little bit higher than normal. And so with this, I do kind of want to point out, with my septic shock having that high cardiac index, we're not saying their cardiac index is going to be hanging out at like a 7. Their cardiac index is probably hanging out at like a 4.5 or 5, But when you take into effect everything else is dumping down, you would expect this to be on the lower side of normal, not on the upper side of normal. But it's just because they're really tachycardic, we're getting a lot of movement through that heart. Okay, and so like I said, I use the cardiac index to say, how's my left ventricle functioning, what's being pumped out into the system, and then I use my SVR to say, how's the body responding to what my heart's doing. Will we ever need the PA number? So your actual pulmonary artery number, no, you'll need your pulmonary artery wedge pressure is the number that you're going to need to pay attention to. Right? If you take out a whole set of numbers, it makes life way easier. And like I said, I mean, not to brag, but I have my FPC, CCP-C, and CFRN, and these are the only numbers that I, routinely look at. So I didn't like throw in additional numbers when I went through and took my test. So just worked for me. Not saying that if I was going through and I don't work on a CV-ICU, I do have a couple of friends who still work on CV-ICUs or cardiovascular ICUs. They look at these numbers all the time and they actually pay attention to all of them, but that's their specialty. Okay. So if you are constantly transporting really sick cardiac patients, that's the time where you really want to go through. And if you are monitoring these, like I said, we don't typically have the option to monitor anything except for potentially a wedge pressure with some of these patients. So keep that in mind. We may or may not be able to actually monitor all these, but if you are monitoring them or if you are transporting routinely these really sick cardiac patients, if you happen to have, I know like in my area, we have a hospital system where they have a fantastic CV-ICU, but they don't really have a great step-down unit. So they'll actually transfer patients from their CV-ICUs out to one of the other level 1 centers if they need additional surgeries. So it just kind of depends on the area and what you're looking at as far as the type of patient populations that you'll see. Thank you, staying late, breaking it down. Good. So what other questions do you guys have? Is there anything else that I can clear up for you guys? Nothing there? Like I said, don't panic about things. If you can just kind of conceptually think about where blood's flowing and where the blockages are, then it's going to make it a lot easier. And I think this is something that a lot of people really panic about, and they look at these numbers and they're like, I don't even know what we're looking at. I don't know what all these values mean. I didn't even realize like there were all these different systolic and diastolic pressures that I have to be paying attention to. But if you break it down and just say, where's my problem? Do I have a problem feeding in? Do I have a problem going out? Do I have a problem in the lungs? Is my left ventricle tanked, or is my body not responding properly? Will really kind of lead your way. Where we see a little bit more of this used in the kind of transport environment or in the real world, we'll start to monitor like their SVR and stuff like that to make sure that we aren't over pressured or using too many pressors on somebody. So if you do have somebody where, say, we had all of these, where did I throw my eraser? We have all these lab values. So let's say we had somebody where their, oops, we'll say we have somebody where their CVP, we'll say their CVP is at 8, their wedge pressure is at 13, their cardiac index is at 4, their SVR is hanging out at 1600. So my CVP, a little bit high, my wedge pressure, borderline high. I note that my cardiac index, actually, let me change my cardiac index to like 3 here. Yeah, we'll go 3. My cardiac index is 3, which is kind of right in the middle. My SVR is hanging out at 1600. So this might be somebody where, say, like post-cath or, some sort of cardiac event. I was thinking maybe this person had some sort of cardiogenic shock. Maybe they came in, they had some sort of MI prior to this. And we went through and we tossed them on a whole bunch of pressors, because in the SVR hanging out of 1600, probably not really the body's response, especially considering my cardiac index isn't that bad. So it's not a forward flow problem. It's me going through and giving somebody too many pressors. Okay.